Hi, my name is Connie Kaplanis and you're watching the video Duane's Retraction Syndrome, Clinical Characteristics. In this video, I will provide an overview of the clinical presentation of a patient with Duane syndrome and discuss the expected clinical outcomes of orthoptic investigations. Duane's Retraction Syndrome is a congenital condition. It cannot develop later in life. But not all the clinical signs associated with Duane syndrome may be noticeable at birth. And over here to the right, we have a table from Ansons and Davis which indicates the various signs that are associated with Duane syndrome and the mean age of onset. And we can see that the first thing that's noticeable is the limitation of eye movements. For some patients, about 30% of them, Duane syndrome can also be associated with other developmental disorders. For instance, a patient with Duane syndrome may also have Mobius syndrome. So if the patient is suspected to have other disorders, they should be referred on to a paediatrician. The Duane syndrome can be unilateral or bilateral, and unilateral Duane's is far more common, with 80% of patients having a unilateral Duane syndrome. And then when it is unilateral, the left eye is more often affected than the right, and also females seem to be more affected than males. In terms of the clinical characteristics of Duane's retraction syndrome, one thing we will notice is limitation of abduction and or adduction. Now, depending on the type of Duane syndrome that the patient has, and we'll talk about types in the next video, the patient may either have both abduction and adduction affected, or they may have more abduction affected than adduction, or the other alternative, more adduction affected than abduction. Again, we'll come back to this in the next video. So firstly, we'll see a limitation of horizontal movements, and this will vary depending on the type of Duane's. The next thing is that we may see retraction of the globe on adduction and narrowing of the palpable fissures on adduction. Let's now look at our patient here to the right. This is them in prone position here. This is the patient looking over into right gaze, and this is the patient looking into left gaze. In prone position, the patient looks relatively straight. When we look over into left gaze, the left eye has limited abduction. Okay, so that's probably about a -3 there. Now, when the patient looks into right gaze, over this way, what do we see? We see perhaps limited adduction, and we see a downshoot of the eye as well. But aside from that, we also see that the globe seems to be retracted and the palpable fissures are narrower. So you can see that that is narrower there than what you see in primary. And this is a side shot here of the patient looking in prone position versus the patient looking in adduction. And again, you can see here that the globe, comparison in primary to right gaze, there's a retraction of the globe and a narrowing of the palpable fissures. Why does this happen? It's the co-contraction that's causing this retraction and lid changes. So when the patient is attempting to adduct, the medial rectus is being innervated along with the lateral rectus. The lateral rectus is an opposing muscle. It's an abductor, not an adductor. And as a consequence, the globe is retracted, and we see these narrowing of the palpable fissures. These are classic signs of Duane syndrome. It's worth noting that the amount of retraction of the globe and the narrowing of the palpable fissures you see does vary between patients. Some patients will have more retraction and narrowing of palpable fissures than others. This comes back to the amount of co-contraction that's occurring. So where there's strong co-contraction, so you've got the lateral rectus going hard up against the medial rectus, you're going to get much more retraction of the globe and much more changes seen in the palpable fissures. However, where the co-contraction is not as great, then this will produce less of that mechanical sighting of, or the mechanical characteristic of a retracting globe and a narrowing palpable fissure. So we've talked about in previous videos that where you see limited abduction, as we do in this patient, you need to consider a sixth nerve palsy, and if it's a child, a congenital sixth nerve palsy is an example. So what you're looking for to differentiate between the sixth nerve palsy patient and the Duane's retraction syndrome patients are these lid changes, the globe retraction and so forth. These do not occur with a sixth nerve palsy. And lastly, I have here a widening of the palpable fissures. And if we take a look at the patient here, and this occurs, or the widening occurs in abduction. This is them in primary position, and here is the palpable fissure size there. And when they look over into abduction, we can see a widening there of the palpable fissures. This occurs due to the limitation of abduction. It's not as characteristic for Duane's. It does happen in sixth nerve palsies on occasion as well. So it's really that lid retraction and lid narrowing that assists you in differentiating between a sixth and a Duane's. In primary position, you may not see any strabismus in a Duane syndrome, and this also assists you to differentiate it by a sixth, because a sixth with limited abduction should have an esotropia. Duane syndrome, on the other hand, could actually, you could have a patient who's straight in primary despite limited abduction. However, where a patient has mostly abduction limitation, they are usually esotropic if they're not straight. And then if the patient has limited adduction, then these patients are usually exotropic in primary position. Patients with Duane syndrome may also have AV patterns or upshoots or downshoots in adduction. Let's have a look at the patient here to the right to utilise as an example. So here we have the patient in prime position. There seems to be an exodeviation here. When the patient looks over to the left, to the right, there appears to be good abduction and good adduction here. As the patient looks over to the left, we can see that there appears to possibly be a limitation of adduction, but there's certainly an upshoot of that eye there. That's what makes it difficult to look at adduction here. But there's an upshoot of the right eye in adduction, which is characteristic of a Duane syndrome. We have what appears to possibly be narrowing of the palpable fissures and retraction of the globe. It's difficult to see in this particular image. We would need perhaps an exophthalmometer, or just to simply look at the patient from the side to see changes in globe retraction. If we take a look at the patient now between up gaze and down gaze, we can see that there is a V pattern in this particular instance. Okay, so the AV patterns tend to be associated with upshoots or downshoots, or they can be associated with improvements in abduction. So this patient doesn't have limited abduction, but those who do, you can sometimes see an improvement in the abduction in down gaze as an example, in which case you usually see an A pattern, or you may see improvements in abduction in up gaze, in which case you usually see a V pattern. In terms of the upshoot that we see here, why does an upshoot or a downshoot occur? Patients with Duane's retraction syndrome may also have AV patterns or upshoots and downshoots in adduction. Let's have a look at the patient here to the right as an example. So here in primary position, we have an exotropia. The right eye is exotropic. In right gaze, abduction looks good here and adduction looks good. And we're not seeing anything there that looks like a Duane syndrome in this particular position. There's no globe retraction here. There's no narrowing of the palpable fissures. When we take the patient over into left gaze, however, we can see here that there appears to be limited adduction. Abduction of the left eye seems fine, and we certainly can see an upshoot of that right eye in adduction. Let's have a look at up gaze and down gaze. If we compare up gaze now to down gaze here, we also appear to have a V pattern. In terms of AV patterns, they generally occur where there's upshoots or downshoots, or they can occur when there's limited abduction, which is not the instance here, but where there's limited abduction can improve in down gaze for some patients, in which case you often see an A pattern, And for other patients, the abduction may improve in up gaze, in which case you see a V pattern. In relation to upshoots or downshoots, these are generally caused either because of a mechanical issue or an innervational issue. Where it's mechanical, we get a leash effect with inappropriate firing of the lateral rectus, or we can get globe slippage around the tight lateral rectus. Here we have a schematic diagram depicting globe slippage around the lateral rectus. So what we have is the globe, we've got the lateral rectus here and the medial rectus here, and the eye trying to move into adduction. In this instance, it's depicting a downshoot, but what's happening is that as the patient moves into adduction, eventually we have this downshoot as the lateral rectus slips off the globe or the crest. This can similarly occur for an upshoot. If, on the other hand, the upshoot or downshoot is caused by innervational issues, this is actually a co-innervation of the vertical muscle in the medial rectus. So, you know, Duane's retraction syndrome is a miswiring of the third nerve, and it's going both to the medial rectus and the lateral rectus. Well, what can happen for some patients is a further miswiring, where it's now going to the medial rectus and also to a vertical muscle. So if, for instance, the medial rectus and the superior rectus are being innervated, then we're going to see a upshoot. So it could be either mechanical or innervational that's causing these up or down shoots that we see in adduction. Patients with Duane's retraction syndrome also have restricted areas BSV. Now you can imagine this, given that these patients can have limited abduction and limited adduction, the area BSV can be quite small for some patients. Now this will be dependent on the deviation in prime position and the ocular movements and the limitations they have, or the extent of the limitations that they have. Now, to centralise their area of BSV, if they do not have aligned eyes in primary position, they will utilise, or patients will utilise, an abnormal head posture. Now, the abnormal head posture will be influenced by what is present in primary position and, again, the limitations in the eye movements. Most commonly, a patient with an ET will turn their head to the affected eye, and the XT patient will turn their head to the unaffected eye. And also be aware that with near and distance gaze, the head posture may alter in terms of size and may be more exaggerated in the distance or at near. Where there's an AV pattern, there could also be a chin up, chin down, depending on the significance of that AV pattern. Let's have a look at the patient here to the right, and we see the patient looking into left gaze up here, and we can see the limited abduction here. And then the patient's looking into right gaze, and we can see limited adduction and the upshoot that's occurring here. The below image is the same as the middle one, so it's not adding here to any descriptions of what's happening with the eye movements. But what we can see is the patient has a turn to the right, and in doing so, she's keeping her eyes to the left. So this particular patient is moving their head to avoid that adducted position where there is a significant upshoot of the eye there. Okay, this is a depiction of a patient's area of BSV. This patient has a very restricted area of BSV, particularly so as they have both adduction and abduction affected. So what we have here is a small area of BSV with right gaze affected and left gaze affected. Now for this patient, luckily, primary position is unaffected. But as soon as they move slightly into left gaze, they've got diplopia, and soon after, about 20 degrees here, they have diplopia when they move into right gaze. So they have very little area of BSV horizontally, and a little bit more so on right gaze than left gaze. In summary, the features that we see in a patient with a Duane syndrome relate directly back to the etiology, to the agenesis of the sixth nerve nucleus and or its fibres, and to the co-contraction of the medial rectus and the lateral rectus. So, those key features we're looking for is limitation of abduction and or adduction. That limitation in abduction relates back to the agenesis of the sixth nerve. Limitation in adduction relates to co-contraction of the medial rectus and the lateral rectus. In terms of the features that we see on adduction, this relates again back to the co-contraction of the medial and lateral rectus. So in adduction, what we see is narrowing of the palpebral fissures, retraction of the globe, and in some patients, upshoots and downshoots in this position. Okay, that brings us to the conclusion of this video. Thank you for watching.